Hi guys, let's begin with the next chapter, and now we are actually starting with the different kind of viruses. So we are first starting with the DNA virus family. I hope you all remember the mnemonic of the DNA viruses, that is happy. And under it, the first thing that we are going to consider is the herpes viridae family. So a lot of herpes coming up your way. Let's first begin with the classification of the herpes viridae. So we have human herpes virus, HHV will stand for human herpes virus. And this is going to go on from 1 to 8. So first and foremost, let me sort out the simpler ones. Human herpes virus 6, 7 and 8 are known by the same names, 6, 7 and 8, right? Human herpes virus 1, 2 and 3 are a separate group because they belong to herpes simplex wala variety. So this means this is going to be herpes simplex 1 and this is going to be herpes simplex 2. How simple? Human herpes virus 1 and 2 is nothing but herpes simplex virus 1 and 2. So 1 and 2 is 1 and 2. But what is human herpes virus 3? That is also part of that family. But that is known as herpes zoster virus. Okay, it's going to cause chicken pox, zoster. So herpes zoster virus. So simple. 1 is going to cause HSV1, 2 is going to cause HSV2, 3 is going to cause herpes zoster. What is 4? 4 is Epstein-Barr virus. And fifth one, bigger number, that is cytomegalovirus. And cytomegalovirus is the largest member of this family. Of the name, of course, suggests us cytomegalovirus. Okay? So now this is exactly what we are going to do. We are going to study one by one from 1 to 8. We'll study everything. But first, let's do a basic overview. Let me see how much of general virology you have revised. So tell me the general properties. What is the size? 150 to 200 nanometers. Can you please revise with me? What was the largest virus? The largest was pox, which was somewhere around 300 nanometers. And the smallest was parvo, which was parvo. Remember parvo from Devdas? And parvo was very, very tiny, 20 nanometer. The largest was pox, 300 nanometers. This is somewhere near to pox. So herpes viridae family 150 to 200 nanometers. It's the second largest. What is the symmetry? I had told you all the DNA viruses. All the DNA viruses that you have a icosahedral symmetry. And icosahedral symmetry except pox. Pox was complex. Remember, pox had complex symmetry, but icosahedral for all other DNA viruses. What kind of DNA? All DNA viruses are double-stranded except parvovirus. Parvo was single-stranded, rest all are double-stranded. So this is a 150 to 200 nanometer icosahedral double-stranded DNA. So like I said, now you won't have to repeat all of this because if you've done a general virology, your concepts are clear. Now let's go on to the classification that is followed. Instead of putting it HHV 1, 2, 3, 4, 5, 6, 7, 8, they put it into alpha, beta, gamma. Means the ones that I'm talking about, that is HHV 1, 2 and 3. Can you recall their names? They were herpes simplex virus 1 and 2 and herpes zoster virus. You know, where do they reside? They reside in the neurons, their latency. Where are they going to sit? In the neurons. That is why they are put under one category, subfamily called the alpha herpes viridae. Then next number kya hai? 4 and 4 ka double 8. What was 4? Guys, 4 was Epstein-Barr virus and 8 is human herpes virus 8. They have been put under the gamma category. Why? Because they have a common site of latency, that is the B cells. In a while you will see Epstein-Barr virus goes to B cells. Human herpes virus 8 also looks like a B. So that is also going to go to the B cells. Okay? So simple to learn. Epstein-Barr virus is going to have a B and B looks like, of course, B will be B. Whereas human herpes virus 8 looks like a B. So that is also going to be involving the B cells. Ab kya bacha? Now, ma'am, the T cells are left. Who are going to go to the glands and the T cells? The numbers that are left. That is 5, 6 and 7. So human herpes virus 5, which is nothing but cytomegalovirus, along with 6 and 7, they are going to go to somewhere in the glands and T cells and they are said to be the beta variety. So simple, we have alpha, beta and gamma subfamilies. Alpha has 1, 2, 3, then 4 and 8 go under gamma and remaining numbers come under beta. Let's begin one by one. My first set of discussion is going to be the HSV 1 and 2, herpes simplex virus 1 and 2, which I'm going to take up in the form of a diagram or a table. So simple. Above the waist is HSV1 and below the waist is HSV2. What did I say? Above the waist. I'm going to change the table a little, okay, for our mnemonics. Above the waist, whenever they say there is an orofacial lesion, something to do with herpes labialis or, you know, anything to do with the face, gingivostomatitis, kuch bhi much above the face, anything to do with orofacial lesions, it is HSV1. When they say any kind of skin lesion above the waist, HSV1. Brain, of course, is much above the waist. So, of course, HSV1. So, encephalitis, meningitis, these are all HSV1. What is going to be HSV2? Everything below the waist. So, below the waist, to genital hoga. So, of course, when they say genital lesions hua hai, anything that is coming below the waist will be HSV2. Also, mother to child means neonatal herpes. Anything that has gone from mother to child, of course, that is also mother to child through the vaginal tract only, na? Through the intrauterine or vaginal tract. So, below the waist. So, anything below the waist, including neonatal, is going to be HSV2. So, now tell me the transmission of these two. So, obviously, if you're talking about orofacial lesions and skin lesions above the waist, this means this has come either from skin or from mucosa. The entry has either been the mucosa or the skin. And if you're saying HSV2 is below the waist and it is everything like genital matlab sexual hoga and neonatal matlab mother to child hoga. So there is going to be sexual and vertical. Vertical means mother to child. Right, so HSV2 has sexual and mother to child transmission. What is their latency? So now latency, tell me. Again, think of above the waist and below the waist. Above the waist wala will be latent in the trigeminal ganglia. Below the waist one will be latent in the sacral ganglia. Age group is also simple. When you're talking about genitals, of course, you're talking about sexual and genitals. So you're talking about adults. So HSV2 genital wala is in adults. Unless you're talking about neonatal, then that is different. But HSV1 then becomes more common, not in children, but younger people, I would say. Okay? So if you would have just learnt a very simple trick of HSV1 is everything above the waist and HSV2 is going to be below the waist, life becomes much simpler. Now let's come to the microbiology part. Who is going to show you a growth on chick embryo fibroblast? So who is going to grow well? HSV2. Who is going to be more virulent and more resistant? All the more things. HSV2, the elder brother says, I will grow on the chick embryo fibroblast cell line. I will be more virulent, neurovirulent, and I am going to cause drug resistance. Whereas HSV1 is not going to grow well and is going to be less drug resistant, less virulent. Okay, so all this basic is done. Now let's go into the details. Let me ask you. They say there is a case of herpes and you said orofacial mucosal lesions. Orofacial, HSV1 or 2? Of course, we will say HSV1 is going to be the more common. But what is the most common site where it's going to occur? Most commonly, it's going to be the buccal mucosa. And if you're saying buccal mucosa, what is the lesion in the buccal mucosa that is going to be there? It is gingivostomatitis. So the lesion that you will have in the buccal mucosa is gingivostomatitis. Primary lesion. If a lesion is happening the first time, it is gingivostomatitis. But if they say which is the most common recurrent lesion, bar hoga, so that is going to be herpes labialis. That is known as herpes labialis. So please note these three questions. Question number 1, most common site buccal mucosa, kya hoga first time? Gingivostomatitis. If it has to have multiple times, repeated times, then it's going to be herpes labialis. So orofacial lesions ho gaya. Let's pick up the next organ. Let's talk about CNS infections. Now tell me one thing. CNS, much above the waist. So what are you expecting? HSV1 I am expecting should be much more common than HSV2. So encephalitis mein, there are two questions coming to me. This is the most common cause of acute sporadic viral encephalitis in the world. Acute sporadic viral encephalitis is going to be HSV1, and which is the part of the brain that is affected? It is usually the temporal lobe that is affected. Okay? So the most common cause of acute sporadic viral encephalitis. But listen to me carefully. This was encephalitis, fine. If they ask you about meningitis and they particularly ask you about molarette meningitis. Firstly, you will ask me what is molarette meningitis. It is a kind of a recurrent lymphocytic. Dekho, molarette had lots of L's. Molarette had lots of L's. So it is a recurrent lymphocytic meningitis. It is a recurrent lymphocytic meningitis that is there. So now this, you will say meningitis hai, to ma'am anything above the waist is more common with HSV1, but that's the trick. This is more commonly seen with HSV2. That is what I want you to know a catch for. So remember, molarette meningitis, which is lymphocytic meningitis, is more common with HSV. Let's move on to the next one. Ocular. Ocular lesions kiske saath zyada honge? Common sense, ma'am. This is also much above the waist. So HSV1 is going to be more responsible than 2 for the ocular regions. And what are you talking about? You are talking about dendritic corneal ulcers. We are talking about dendritic corneal ulcers. Finally, coming to genital lesions. Come on, this is understood. Finally, I come down to genital lesions, and I know HSV2 is going to be more common. So, whenever a genital lesion, I'll show you a picture. You can see a lot of genital ulcers formed over here. Whenever a genital picture comes, you ask me painless? Yeah, painful. So, what is the condition going to be? It is going to be bilateral painful vesicles with painful inguinal lymphadenopathy. By now, you have finished bacteriology. You know what are all the genital ulcers which are going to be painful. Can you quickly give me a history, a quick 1, 2? There are just 2 genital ulcers which are going to come with a lot of pain. Painful ulcers. The first one is in front of you, that is herpes simplex virus 2. And what was the other one? Where in bacteriology? Haemophilus ducrei. Because I told you ducrei may the patient is gonna cry with pain. There is going to be a lot of pain. So remember, herpes simplex virus 2 and there is going to be Haemophilus ducrei. They are the ones which are going to come as painful ulcers. Okay? So coming back, they are painful, not only painful vesicles and ulcers, but also the lymph node that is formed is going to be painful. That is the genital ulcers. Finally, we come down to miscellaneous wala. So can healthcare workers also have this? Yes, we are dealing with patients. We are handling their lesions. We can also have it. So what is that known as? So maybe this is the kind of a lesion that can come up in a healthcare worker who's dealing with patients, and that is known as herpetic whitlow. Herpetic whitlow is something which is seen in the hands of the healthcare workers, right? You've seen that, you will remember it. So while dealing with patients, you have to take precautions. Is there something that is known as herpes gladiatorum? Gladiatorum, gladiator jaisa, something big, bulky, heavy it is sounding like. So this is the one that is known as wrestler's herpes. So gladiatorum, gladiator jaisa, wrestler's herpes. Other than that, it is associated with eczema herpeticum and erythema multiforme. These are other miscellaneous things. I expect a question either on gladiatorum, that is wrestler's herpes, and herpetic whitlow, which is going to be in the simple. Herpetic whitlow is hospital workers or healthcare workers. Healthcare workers में there is going to be herpetic whitlow. ठीक है? Chalo, now moving forward, let's do the lab diagnosis. You have this question which has been asked 10 times. So I'll put like 10 star if I can add, not even 5 star. 10 star question. What do we do a Zank smear for? Zank smear is done for everything. It is done for HSV1, it can be done for HSV2, it can even be done for that herpes zoster virus abhi baad mein. So you will ultimately realize that the disadvantage is that it cannot differentiate between any of these. It is done for everything. Therefore, and also one more problem is iska sensitivity is low. So what exactly is a Zank smear? So Zank smear jo hum lete, please note a Zank smear is going to be taken from. So the first question is, where and how is a Zank smear taken from? So whatever lesion you are dealing with, whether it is above the waist or below the waist, you are going to unroof the vesicle. So ideally you prefer that you should take a fresh vesicle rather than a crusted one. But even if it's crusted, you first have to remove the crust and then you are going to scrape the base of that particular lesion. Whatever lesion is there, you scrape the base and then you stain it with what? There are a couple of stains that are there. Giemsa or Wright stain. Do you remember from pathology, Giemsa or Wright stain come under which family? They come under the Romanowsky stain families, right? So they are the Romanowsky stains you can use, or you can use the toluidine blue. And what are you going to see? That is the question. I'm not going to tell you that. We already know. I've told you in the previous chapter. What do you see in herpes simplex or herpes zoster virus? What is the cytopathic effect? I told you, you see the 3 M's. What is 3 M's? We'll quickly repeat. Same slide from the previous chapter I've got you. Number 1, it shows you multinucleation. So none, 2, 3, 4, 5, lots of nuclei. All of them are fitting into each other. That is molding. All of them are fitting into each other. That is molding. And finally, there is going to be margination of the chromatin. So remember, multinucleation, molding, margination. And there's another test that I'm taking. Which body do you see? Abhi padha hai previous chapter. You have to be knowing. We see the famous Cowdry type A bodies. Very good. Naam yaad aa raha hai? What is the name? Leib-Schultz bodies. Leib-Schultz bodies, yes. And now your story is complete. If you were able to answer this, tick mark karo, give a pat on your back. You have done general virology very, very well. So Zank smear ho gaya, but the problem is that its sensitivity is low and it has a disadvantage that you cannot differentiate between the other species. Chalo, done. What else? Ma'am, Zank smear to anyway you said ke zyada useful nahi. So theek hai, kar liya. Which is the best thing? The best is isolate. Like in bacteria, I used to say culture media, best Back blood agar, chocolate agar, all those. Here you can't use culture media. Here what do you use? You do some kind of cell line. So you're gonna isolate it and grow it in some kind of a cell line. That is one definitive way. Can you do DNA testing? Of course, we can do PCR. We can do PCR, which is also said to be very sensitive. But the problem is that PCR cannot differentiate HSV1 from HSV2. Why? You don't need to know the why as such, but let me tell you, HSV1 and HSV2, approximately 80% of the antigens are the same in them. So, PCR will, how will it differentiate? When both of them are almost like twin brothers, how will a PCR differentiate? So, PCR is also not able to. What else can we do? We can do DNA studies. How are DNA studies done? DNA studies are done by polymerase chain reaction. Yes, this is gonna definitely be sensitive. And we know that this can differentiate between HSV1 and HSV2. This can differentiate between HSV1 and HSV2, although there are very minor differences in the antigen homology of HSV1 and HSV2, but PCR can do that. Finally, what are we going to do in serology? Like always, we do ELISA, and if there is a four-fold increase, in antibodies, it is suggestive of herpes. What is going to be the drug of choice? Before I go on to that, kya kara? You did a Zank smear for seeing that triple M. Then you did viral isolation in cell lines. You've done DNA, which is sensitive, and you've done serology with ELISA. 4 times increase in antibodies suggestive. What is the drug of choice? We are going to definitely go on with acyclovir. And what is acyclovir? Why are we giving it? Because this is going to go. What is the mechanism of action? It inhibits the DNA polymerase. That is the mechanism of action that you all have studied, right? It inhibits the DNA polymerase. Now also tell me that if there is resistance to acyclovir, what is the drug given in pharmacology? Then there is going to be foscarnet.